Members of the audience, respected Professor Gangakhedkar, today's chief guest, who will be delivering the keynote address, and my co-chair, Padmashree, an old friend. Well, ladies and gentlemen, I'll be briefly introducing Professor Gangakhedkar after 1 or 2 minutes, but before that, I'd like to give you a glimpse of what Professor Gangakhedkar has contributed in our field and how he has reached that level of a luminary. I remember the late 1980s and the first half of 1990s. I then posted as a faculty member at AFMC Pune, and I was also looking after the AIDS and HIV surveillance of armed forces. The situation at that time, believe me, was as if some Holocaust has come. In fact, many of the epidemiologists and physicians over the globe were led to believe that maybe half of the world population may not be able to see the next generation. It was so bad. And how the overall problem in our country even, which was supposed to be around 7 per thousand positivity among the general population that time. I'm talking of the early 90s. It has come down to as low as 1 per thousand now. It's one of the biggest success stories. The National AIDS Control Program, which has been heralded and under the wings of luminaries like Professor Raman Gangakhedkar, is one of the biggest success stories in public health in the modern times. It is not what I am saying to eulogize Dr. Gangakhedkar, but it is documented. And with that background, his huge achievements, his tall qualifications would take a long time, but I'll just quickly, briefly introduce him, his achievements and his contribution. Professor Gangakhedkar presently is a distinguished professor, Symbiosis International Deemed University. He has held very, very important appointments. Formerly, he was the national chair of the ICMR. Formerly, he was the head of division of epidemiology and communicable diseases at the ICMR. He held a very, very important, and that was the appointment in which he actually contributed a lot to the National AIDS Control Program, and he was the officer in charge director of NARI, the National AIDS Research Institute at Pune. He has a large number of very reputed memberships. Some of them I would read out. He has been a member of National Task Force on COVID-19, a member of the WHO Scientific Advisory Group for the origins of novel pathogens. He has been a member of the Standing Working Group of the NTAGI, which is our apex body in the country on vaccination and immunization. Professor Gangakhedkar has also been awarded a large number of awards. I'll only read out some very, very tall awards, and of course we start from the prestigious award of the Padmashree by the President of India in the year 2020. He was been awarded the Doctor of Sciences by the Datta Meghe Institute and D.Litt by the Symbiosis International University. He has been awarded the Marathwada Bhushan in 2023, the late Dr. Shankarrao Chauhan Jeevan Gaurav Puraskar in 2022, the Lifetime Award of the AIDS Society of India in 2022, the Swami Ramnath Tirth Marathwada Gaurav Puraskar in 2021, and the Lifetime Achievement Award by the Army Institute of Technology Pune in 2021. These are just a glimpse. There are many, many awards, but I am sure we will be waiting now to listen to Professor Gangakhedkar, who will now tell us the course, how he did it, how he did this miracle, and what does he expect us to do in future. Professor Gangakhedkar, sir.
Immediately, sometime around 1986, I was not there then, but just look at the scenario there. Because I think 1986 1999 into the field of HIV. The first thing was there was a extreme denial when the first few cases among sex workers were detected. And that denial was to a tune that one could not believe. The announcement that they had to make, even in Parliament, was a very difficult challenge because nobody could believe that HIV is very much here. At that time, even discussions on sexuality was a taboo. If you look at the diseases, the disease that spreads through socially unacceptable behaviors is bound to evoke all kinds of reactions from the people. National STD control program was almost non-existent. It was a program which was actually established in the pre-independence era by Britishers, but there was hardly anything that was available then. Blood safety program was so rudimentary that there was only peripheral smear for HPUs to be done, VDRL and HPSAP, and that was about it. Healthcare infrastructure was not used to handling behaviorally transmitted infections, which was very much tough, and they did not have access to the key subpopulations to which we continue to refer now as those who made a huge difference. And our per capita expenditure on health was so low. I recall in those days it was reported to be somewhere around 30 rupees per capita. Now even if you were to introduce ELISA, so perhaps all the expenses would have been taken care of by this ELISA itself. But then how did we move? If you actually look at, I recall in 1989, people used to say, and he was one of the best epidemiologists, Dr. Jim Chin, he came out with one projection. They said that by 2000 AD, you'll have almost 4 crore people infected by HIV in India. And that was a very scary thing at that juncture. Now, if you look at 37 years that have lapsed after the first report of few cases in Chennai, you find now HIV/AIDS or HIV disease, as we call, it's accepted by a majority, all the stakeholders as of now. If you look at discussions on sexuality, perhaps there is no such taboo at this point in time. You have recognized and mobilized the socially challenged group so well that they are getting involved in policy making in every way. But I must also say that kind of involvement which was there earlier is perhaps no more existent. It has come down dramatically, and that's a pain which we will talk about subsequently. When it comes to blood safety, the entire thing was taken by NACO, and actually the program was so well developed. Now today you have fractionation services which are also offered under the same program, which operates under National AIDS Control Organization. The services related to HIV have been integrated even up to sub-district levels as of now. The track record that we have right now is almost 20 years of ART services, 22 years of mother-to-child prevention of mother-to-child transmission program, and 27 years of targeted interventions that we have, and we have matured really well. We are closer to elimination targets for 2030, despite the fact that this is a chronic viral disease. You don't have a preventive vaccine, you don't have a cure. It's only about 4 decades old infection, even in the world, and still we talk of elimination as of now. So why did this happen is a question that will come to everybody's mind. To me, one of the things which I would definitely say is the dramatic, rapid, and progressive response that came from policymakers that made a huge difference. If you look at the HIV infection which was detected in 1981, you will find that the first HIV surveillance It was a passive surveillance. We were not used to doing it properly, but it was started in 1985. And then the first cases were discovered. I can also tell you, though we talk of these first cases as such, the first case actually that took place was elsewhere rather than Chennai. If you look at the records that you have in ICMR. The National AIDS policy that was developed in 1987. HIV as transmission transmitted infection, this was recognized in 85 globally, but in 1989 the professional donors were banned in India. So very little time between that period and we changed the whole thing. If you look at HIV-2, it was first identified in 1991 and look at the strength of the program. The program introduced HIV-2 ELISA as well. It was HIV-1 and HIV-2 ELISA within 1.5 years period after a report of HIV-2 in India. It's not a simple task. Those who work with the government, they will realize that if you want to spend 5 rupees more or train people on a newer test, you will find it extremely difficult to roll out in a short period of time. Prevention of mother-to-child program, the discovery of the drugs that you could use against them were reported in 1994. The first report came from nobody. But by 1999, we rolled out our own program. So within 5 years, look at the massive country that we have. We first started with 11 centers of excellence, and here the study started, and by 2002, 2001, PMTCT was also rolled out. If you look at ART first line, we rolled it out in 2004. The rest of the world had rolled out in 1994. But we were lucky. We did not use their drugs, which were PI-based regimen. They could have damaged the program very badly. We were lucky we went on cheaper regimens which contain NNRTI-based medicines sometime in 2004. If you look at second line drugs, second line ART, that started in 2008. So if you look at the rapid response that the government gave was immense in terms of changing the projections that they had shown earlier. Now if you look at National AIDS Control Program, the first program that started was in 1990. It used to be 5 years program, fully supported by World Bank. And during that period, what was the key feature? The key feature was simple. You wanted to ensure that people become aware, start some kind of screening services of HIV can we actually make this bigger? I am not able to see this. Next slide. 1994, the realization that this is a sexual-driven program actually came out, and the first funded program internationally for Sonagachi actually came out in 1994. So historically we always say Sonagachi was first, but that is not true. It was a heavy project in Pune, and there was one in Kamatipura that started running far earlier compared to Sonagachi. But it made a remarkable change. In that particular period, we recognized that this is a sex-driven program, whereas rest of the world was struggling with who should they target. No? India was one of those countries which first focused on sex workers, clients of sex workers, and then we started moving on the classical Bruce Weniger model that we had. Now, since that was done, the spread actually became far lesser compared to what people thought, because it was not, it was, the focus was so intensified among sex workers, IDUs and MSF that things started moving out. Though I must make a correction. MSN programming was not so strong in the beginning compared to sex workers programming or even injecting drug users programming. Why do I think these were very important? You have to recognize that MSN, they used to have pinoanal sales that was legally not acceptable. Now, if you look at injecting drug use, you could be, your laws would not allow even going to them, even knowing who is pushing these drugs. But NACO took a bold step. They said this is for social welfare, this is for the health of the people. Despite the fact that this was a government agency, it started supporting projects, which means you directly fund for certain activities to reduce the harm. That's not a simple step for any government department to ever take. That's something which is remarkable. In NACP phase 3, the EIs, they were scaled up to a larger extent. You had district focus, uh, mainly because in phase 2 we established structures of SACs, because there was a fear that the money that has to be rolled out for doing all activities tends to get delayed, mainly because it comes through government and there are too many approvals to take. So a non-governmental approach was also not going to work. So it was decided that we will establish societies as one of the structures, which became almost a norm subsequently for all other diseases across. No? Once they realize the benefits with the same. For NACP phase 4, there were many things that had already happened. No, ART, PFTCT, that was already rolled out in NACP phase 3. In NACP phase 4, one of the things that was done was test and treat policy was started at that time. It took little longer while to my mind to roll it out because of obvious constraints that we had to buy too many drugs, because once you say test and treat, it's not something which would be easy. And then NACP was extended, NACP phase 4 was extended until 2020, and then we have now a new NACP phase 5, which is part of it. And why does this become important? This becomes important because the government has committed to SDG goals, uh, where you have to ensure healthy lives and promote well-being at all ages. And then there are elimination targets. If you look at disease elimination targets, you have elimination of AIDS, TB, malaria, neglected tropical diseases, combat like visceral leishmaniasis and things like that. And what is also important is now you have added congenital syphilis, you have congenital vertically transmitted HIV infection, and also hepatitis B. What steps did we take in NACP phase 4 to achieve these SDG goals? If you actually look at it, the AIDS bill, which took a very long time, if you ask me, I think Anand Grover's group had started working on the same sometime in 2002. But it was difficult to change the whole thing into law, and this was first made law in 2017. People used to question why should you have rules of this kind only against one particular disease, but it has now become a prototype that can be used, quoted in the court, even for other diseases. 2017, we went for adoption of test and treat strategy. Test and treat was a critical thing to do. If you test any individual, he comes out as positive, you are expected to initiate ART right away. That is test and treat strategy. Community-based screening, universal viral load monitoring. Just imagine, if you recall, I said our health per capita health infrastructure expenditure was only 30 rupees. Now, when we started in 1990. And for this was the first program where the government said that we will provide drugs lifelong to somebody free of cost. That's not easy to do. Then you added monitoring with CD4 tests, CD4 counts per se. And then subsequently we pushed for plasma viral load testing, which used to be far more costlier. The only place where we have still not been able to do is blood resistance testing. But you are using some simplified regimens, so you don't need to actually do drug resistance testing as much as one would like to demand. And then you have Toluid based ART regimen, which was adopted during phase 4. How did this happen? It happened because of one of the trials where we also participated was HPTN 052 trial. And in that trial, there were serodiscordant couples. They, the person who was the index case was offered ART right away, and then it was observed what would be the proportion of their partners who would acquire HIV infection because they were negative. And what was it that emerged out of it? That if somebody is put on ART, if he is virologically stable or suppressed, you will find that the risk of transmission of HIV infection to the mother, to the partner, is likely to be the least. And it also entails that you will get less number of opportunistic infections. And we started pushing for HPTN 052 adoption because by then test and treat strategy was becoming global. But it took little longer time for us to adopt. It finally happened in 2017, and that has made a huge difference. Why is it a huge difference? Because we could actually limit the numbers close to about 25 lakhs as of now, mainly because our rollouts have also been very stronger. Now, if you look at the pandemics that occurred, you will perhaps remember COVID now, but look at the stark reality. HIV was among the pandemics in our own era as such, and when it started occurring, you look at the period that we still have. You have passed almost 40 years, and more than 40 years have gone in, but HIV continues to be here. So we have to now manage not only those who are HIV infected well, but also ensure that if I want to control this infection, I will have to adopt rigorous policies that will be adopted by the people. You look at where we are as of now. If you look at adult HIV prevalence rate, it's dipping. You look at TLHIV size estimations, they are also becoming far more stable. And they are becoming stable because you are providing antiretroviral drugs, and therefore people don't die, and the numbers continue to be maintained well. How is this epidemic that we have in India? First, it was sex work driven. If you look at now the prevalence rates that are estimated, you will find the highest prevalence continues to be among injecting drug users. What does that essentially mean? It tells you one thing, that my coverage for injecting drug users is lower and substance use is increasing rapidly across in India. And that's something which we have to keep at the back of mind. You will continue to have challenges that would come through MSM population as well as female sex workers. But antenatal women, you have been able to manage to control this infection really well. Now, if you look at the epidemic that we have currently, that is also heterogeneous epidemic. You will find largely the states in northeast have far higher numbers at this point in time, which has to be looked at different way, whether it is injecting drug use driven or are we facing both the kinds of epidemics. One due to injection drug use, and second is also sexual food, because these injecting drug users also have sex partners and therefore it is also one of the reasons why this is increasing. Now, if you want to end AIDS, what are the critical elements to end AIDS? You have to reduce incidence of HIV, and when will it come down? It comes down when you provide quality ART services to reduce the community viral loads. Now that concept of community viral load doesn't exist now, mainly because the prevalence of this infection is so low. Therefore, you can't call it as community prevalence rate, community viral load as one of the main features. But people having detectable viral loads, their numbers are becoming small and smaller. Reduce biological and behavioral vulnerabilities among at-risk individuals, saturate all HIV-infected individuals with ART, and for the vulnerables, you have to provide comprehensive package of preventive intervention and create enabling environment which I believe in empowerment. But additionally, stigma reduction is another issue. Now, how is Government of India proposing to go ahead with that? You will find that is, if I have to go towards the phase 5, what are my targets? Reduce annual new infections of HIV by 80%. This is compared to 2010 bar that we had. Reduce AIDS-related mortalities by 80%. Eliminate vertical transmission of HIV, syphilis, and now hepatitis B. Promote universal access to quality STI, RTI services. Eliminate the stigma and discrimination that they face. That's becoming as much important. Now, one of the things which we have to remember that did the government take right steps? We discussed all the steps that we have taken so far, and they have this structure. What are the new tasks that we are taking in NACP phase 5? That's up to 26. For education, the new generation of communication packages have to be provided. There have to be thematic area-wise campaigns. Now these sound good as strategies, but have you seen those changes occurring? Perhaps not. The focus has diluted to some extent, and that is mainly, to my mind, it is because the program is getting merged into National Health Mission, and therefore part of the activities are going to NHM, and part of the activities are retained with NACO, and therefore the issues come when it comes to strategies per se. When it comes to prevention, we have to ensure that a million of high-risk groups and bridge population continue to remain HIV negative. Now you are suddenly not speaking of what proportion has HIV infection. It is maintenance of those who are HIV negative as HIV negative through is considered as an approach, and therefore you are finding that newer strategies like PrEP is evolving as of now. You want to ensure that EIs focus more on the key populations per se, and community-based organizations have to be incorporated in community mobilization. Unfortunately, this is also one area where perhaps to my mind we are slipping at this point in time when it comes to community mobilization. If you look at for early detection, you have to offer large number of groups, different tests that are available to you, and especially about 8 crore population is expected to be covered by offer of 8 crore tests to people in India. Early infant diagnosis, one of those areas which we will see where there are challenges, has to be strengthened. And around 15 lakh people are currently on ART. Their numbers have also got to increase because those we will look at the coverage rates subsequently. And the comorbidities and opportunistic infections management is becoming important. We have to pay attention to them. You are ensuring that these people will survive for a long period of time by using ART. But what about those age-related diseases that tend to come, diseases that are the conditions that occur because of long-term use of antiretroviral therapy, we will have to ensure that we will be able to offer them. And viral load monitoring is a continuing target. We have to ensure that it will almost become a guideline which would be akin to what you see in the West, but it's still not happening. These are the figures which we have been hearing a lot. What is it? It have already been talked of during introductions. So one of the things which we have to remember is the first gain that we have perhaps seen is number of new infections. These new infections number is getting smaller and smaller as the time has passed by. So when do you say that we have achieved this goal? For 2030, there has to be the number of new infections, HIV infections that could occur in 1,000 uninfected. And there is a definite change in the way now the indicators are coming. Reduction in annual new infections, 90% decline by 2030 from baseline year of 2010. The reduction in annual AIDS-related deaths, the figure continues to remain 90%. And attainment of 95, 95, 95 strategy. What does this mean? That 95% of people who have HIV infection are detected, 95% are linked to the ART services, and of those 95%, you will find 95% have virologically suppressed it. Now, if you look at those figures, what would it mean? That you would have to offer comprehensive prevention measures to the population. You will have to ensure that there will be universal access to quality STI, RTI services, and even for vertical elimination of syphilis and now added hepatitis. We were going on the right path, but unfortunately COVID pandemic struck. And COVID pandemic reduced HIV testing that used to occur so commonly because of the lockdown. Obvious reasons were during lockdown people did not go out, and the result was in new cases that could occur, their detections became less at this juncture. There is some degree of increase in loss to follow-up that has occurred. So Maharashtra was relatively better because we had the DLHA groups who stood strongly, and even they asked for permissions for taking these medicines to different people during lockdown. And Maharashtra government was so strong at that time that they decided to offer them, passes so that nobody stops them anywhere. That has worked, but still, loss to follow-up during that period is the issue. Increase in mortality of HIV-associated infections that occurred, especially TB. TB, the deaths increased, and even to some extent, the new infections have increased, mainly because the person was staying in the same family during lockdown period and has infected others as well. Now, are we on track when it comes to key targets and current progress? You will find that what we up to 2022, whatever the data that is available in the public domain, you will find that the current progress rate in 95, 95, 95 strategy is currently 95% of the people know, 82% of the people know that they have HIV infection out of the total who are positive. When it comes to linking, 86% have been linked. When it comes to virally suppressed, 93% of them are known to be virally suppressed. And HIV infected mothers, those who are on ART, the target comes down to 77%, which otherwise should have been 95%. There are obvious reasons. You can question those figures, which we perhaps have only subsequently. No, if you look at where we are in the third phase of this infection. In the first phase, you tend to have higher new infections and lower at that death. In the second phase, you will always find in such epidemics there are higher deaths and new infections. No? They continue to be at a higher level. And now we are transitioning into the third phase where there are higher new infections than deaths because you are providing antiretroviral therapy to these people. The deaths also come down rapidly. What is our incidence rate? Incidence rate is very, very low. At this juncture, it has already peaked. From there, today it has come down to 0.05. The 0.05 is a very small incidence that we are observing. But we need to be cautious because you had COVID. It is possible that it is likely to impact the emergence of new infection or incidence of the disease, and that for that we need to be vigilant at this juncture. This is Bruce Bannister's model. If HIV is to be introduced in any naive population, the first group that will be affected will be poor group. Then subsequently, the bridge population, which would get infected, will transmit it to the mainstream population of women and children. So essentially, if we adopted a strategy of focusing more on the key subpopulations, and you look at the current coverages for targeted intervention, you will find majority of them exceed 100%, which may not necessarily be the truth, but it is a statistical policy to my mind. But migrants and truckers, migrants continue to pose a challenge. We have to also remember them, but we also need to remember one thing. When the risk, when the size starts shrinking, what is likely to happen? HIV would be limited to the key subpopulations in the end. Now, tighter control over that will decide whether it would be sustainable, even if you eliminate this disease, whether it will essentially remain sustainable per se. You look at the ART coverage among different subpopulations. Because if you want to reduce the risk of spread, you have to have a very high coverage rate for the subpopulations which can spread the infection rapidly, or the transmission efficiency can be high. But if you actually look at these figures, which are official figures of Ministry of Health, since now it is part of Ministry of Health, you will find that the estimates that you have for HIV infection among sex workers or MSF and the current coverage under ART centers, perhaps those figures may differ. What does it essentially mean? You have to have very effective, stronger TIs if you want to firstly reach the elimination target and then sustain the elimination per se. Now, as I said earlier, you have 3 infections which can be transmitted from mother to the baby, and they are HIV has to be eliminated, syphilis has to be eliminated, and even hepatitis B. Though hepatitis B comes under National Viral Hepatitis Program, the offer of interventions is likely to happen only through National AIDS Control Organization, and therefore these 3 have been put in because we have a far better infrastructure in MCH as of now. Now, when you think in terms of how we have progressed in HIV positivity among pregnant women, it has been reducing very well toward June, that it is 0.03% as of now, which is remarkably low. Are we going closer to the targets of 95, 95, 95 among ANC? Perhaps there is room to think that in the third bar, you are seeing it's only 86% of the positive pregnant women initiated on ART against estimated positive pregnant women. So these are small issues of which we have to tackle as a challenge. But what is important? If you look at EID, early infant diagnosis, there are many things which perhaps need to be addressed well. These are operational issues. If we have to ensure that elimination of HIV in the children born to HIV positive mothers has to occur, we'll have to ensure that EID programming also includes so that you can connect these children as well as the mother to ART centers. If you look at what has been happening under NSCP, it has been expanding in terms of service delivery points dramatically over a period of time. The scale up of even testing, excluding even the pregnant women, has been occurring at a fairly good rate at this point in time, and the yields are declining, and therefore there is a worry at the national level that if the yields decline, am I justified in offering tests to each and everyone who comes to me? Now, second thing which we have to remember, the number of people who are HIV infected and are receiving ART continues to around 15 lakhs. There used to be double data entry which had occurred, so the data has been cleaned, but the numbers are not increasing as much as one would like to, because at this point in time, we have also got to remember, if I say 24 lakh people are estimated to be infected in India, I look at only a figure of 15 lakh in ART centers, and therefore there is a reason to worry how I would increase, and that's perhaps one of the reasons why public-private partnership has to become strong and stronger. If you look at second line ART and third line ART, the numbers start shrinking dramatically, which essentially is a pointer either for long survival with the first line, or it also means that people are dying with first line itself, maybe as LFUs, which we have to worry. If you look at the coverage for ART, yeah, and there, if you look at viral load testing, showing virologically suppressed proportions of HIV infected individuals, you will suddenly find that there are figures for public sector labs, which is on the left side, and the figure for PPP labs, where we have outsourced viral loads. You will find there is a significant difference between the proportions when it comes to that, and that's a reason for worry, mainly because you will have to focus on those geographic areas where PPP is actually working, why their numbers are becoming lesser in terms of suppression that is occurring. What is also important for us to remember, that these people are getting older, HIV infected people tend to have premature aging, and therefore offering them care services or preventive services through ART centers as a part of integration into the general health system is going to become important over a period of time. We have now HIV/AIDS bill. There has been large progress that has been done, but still not in all states you have co-birth months, which are required as a part of HIV/AIDS bill. So why do we need a public-private partnership? We have to remember that in India there is a mindset, yeah, that taking care in private sector is a matter of pride, which is very common in India. And it is worse for stigmatized diseases. People tend to get worried. Somebody will see me. People may recognize me, and then why should I go there? I go to the private sector doctor. And there is a very high coverage for every type of service in public sector among HIV infected or vulnerable piece of populations. And PPP would actually add substantive numbers that are still not in the net of public sector ART centers or even any program that we have. So if one needs to enhance coverage with ART, one needs to test more number of people. The more the testing sites, the higher is the likelihood that you will add small numbers by including them in the public-private partnership. Public-private partnership is also vital because this is a stigmatized disease and people seek anonymity. So testing them will be enhanced in the PPP model. Now those who become lost to follow-up, they may go to a private practitioner. Now one of the duties which all of us should have is, if I know that that person is coming from there, is he coming because he thinks he has enough money? Assessments have to be strong. Please ensure that those who can't afford to buy their own drugs are sent back to the government ART centers again, and they continue to accept. People tend to believe now they won't be able to receive drugs or care from the same site, which is not true. But that assessment has to be done by the private sector when people tend to walk off from public ART centers. For enhancing coverage of PID, you will have to include public-private, you will have to have public-private partnership approach, because you are looking at 3 diseases at this point in time, and that can only happen if we have PPP. Private practitioners could also be useful in increasing coverage of PrEP, because PrEP is one issue where they could ask, and that becomes little tough, mainly because I had to go in the public sector setting and tell them I want drugs for as PrEP, which would mean I am admitting somewhere that I am more likely to have multiple sex partners, and therefore you need to provide drugs to me. They may choose anonymity or safe spots where perhaps they would like to take it. So PPP would be a required step to offer multi-component prevention in HIV infection. Most importantly, every medical college, whether it is public or private, is now expected to have an ART center. This is NMC regulation now. It helps medical students to learn not only infectious diseases, but now you have older cohort that is emerging where non-communicable diseases are also increasing. So that would perhaps be one of the best things to happen, even in private medical colleges, and therefore it becomes really important. HIV infection, in conclusion, is one of the eliminable chronic diseases by 2030. The different strategies that have been adopted, and I'm reasonably confident that if we work together in public-private partnership with the progressive outlook that the program has shown so far and flexibility, we would be able to eliminate not only AIDS, congenital syphilis, HIV, and hepatitis B, but we all need to come together, ensure things happen. Perhaps one thing that we need to think about is the decline in advocacy that you are seeing among people who are infected with HIV or those who belong to the subpopulation. It needs to be revitalized if we are to make a difference. Thank you.
Ladies and gentlemen, you just heard the scholarly deliberation from the none other than the doyen in the field of HIV and AIDS, Professor Raman Gangakhedkar sir. We already had, rather he had given us an overview of how this HIV affected us and how over a period of time the government got involved into NACO and NACP from 1 to 5, and over a period of time with the involvement of the partnership of private sector, the results have been very encouraging. And to the extent that now we are talking in terms of elimination of the disease by 2030.
We never thought that we will be able to make difference so much that for a disease which doesn't have anything. At that time, it used to be only counseling, because we didn't have drugs or management of opportunistic infections or prevention. You were focusing on a population which was socially challenged population. Because in the government networks, a sex worker or an MSM or IDU person would ever walk into those clinics? Perhaps not. One of the things which we had to do was empower this community by lending our voices that they could sit with the highest policymakers and decide as to how policy should be shaped, strategies should be shaped. Why am I telling this? Now, you look at the disease, all facets when it started, perhaps they could have led to people running away from HIV infection. But what is the positive message that comes? If you commit yourself for a cause, things can happen. You have to gather like-minded people. Even the government can change the decision. It's all your efforts, communication skills that you have, which can force the government to adopt these different strategies. This is not the last disease belonging to such a category. There could be new one that will come. But don't give up. Fight, commit yourselves, things will happen. आणि एक गोष्ट लक्षात ठेवायची, गव्हर्नमेंटला कान नसतात असं आपण समजतो. दॅट्स नॉट ट्रू. It is your own communication skills. You provide evidence, government is willing to change. There is no person under the sun, especially in India, who would like to destroy our own people. Why would they? No, it's how you deal with them. And one message that I would like to give, never confront the government in public. Please understand. It can be on one-to-one basis. You bring in a lot of community mobilization, things can happen. You have to spend time on communication skills, packaging information the right way, because you have to remember when you spend 1 rupee, the cost is 140 crore rupees. So if it is 1 rupee increase in expenditure, it becomes 140 crore. It's not easy, but you have to keep on thinking those efforts. So don't give up. You will see new diseases coming. Don't worry. And don't even ever think that we are into health transition model and therefore NCDs are going to predominate, infectious diseases go. Please remember, this was first statement that I used to make when I went to ICMR headquarters and head ECD, that even if NCDs will predominate, what will happen? All these NCDs have associated immunosuppression. And when you have immunosuppression, you will find that infectious diseases are bound to increase. So don't give up on either side. You have to keep a balanced approach and go ahead, do it. And we need you, the younger ones. So our era is gone now. We continue to fight, but the entire responsibility is going to fall on your shoulders to ensure health of India continues to be maintained well.
One on this point. Sir, I just request you to give guidance on coordination of these HIV/AIDS and tuberculosis, hepatitis B and RTSs. Yes,
Sir, I think part of it is going to be covered by Dr. Vinay Kulkarni. So I should not trade on his topic. But that coordination will happen because eventually there is a big effort at the government side that we have to reduce the number of vertical programs that we have. So what they are currently trying to do is what we had pushed from NARID, what we used to call as HIV plus model. HIV plus model means there are too many vertical programs. Wherever there is association of HIV with other vertical programs, there should be a horizontal collaboration that should happen and a common mechanism. Like for hepatitis C, the government of India's program is also going to provide treatment to them, those who are Hep C infected. But when it comes to delivery, where will this delivery occur? This will occur through targeted interventions among IDUs, MSL. Now, so the focus is going to be on that process of delivery through National AIDS Control Program. And slowly, when we say something like this, it also means Hep C, you will find, may require longer time in vertical programming, mainly because their structures are overlapping. It may not go into National Health Mission very easily, but there is a strong push towards integrated programs as of now. Wherever mergers have to occur, like for NHM, now perhaps the first program that will go would be the PTCT program. That will perhaps go to NHM very quickly because their coverage is wider. But things will happen. Sir, when Dr. Vinay Kulkarni will talk about.
Thank you, sir. Thank you very much, sir, for your giving your address and making us all wiser. Thank you, sir.
And my apologies that I was sitting. No, they should know. No, unfortunately, after Omicron that I got, the lungs are as bad. But my apologies. Don't misunderstand.
I would request Air Marshal Dr. Rajveer Barwar and Brigadier Arni Kumar Srivastav to give memento to Padmashree Dr. Raman Gangakhedkar. I would request Brigadier Arun Tyagi to give memento to Air Marshal Rajveer Barwar, and I request Dean Sir, so Dr. Padmashree to give memento Brigadier Arni Kumar Srivastav.